Good afternoon, everybody. Today I'm going to talk about the vision correction in advanced keratoconus. To correct the vision in advanced keratoconus, a little bit not a straightforward case. We have to address many issues. We have to address three issues actually. The first one is we have to address the progressive nature of the disease. So we have to be sure that there is a stability of the cornea either by cross-linking or by the age or by the follow-up. For the criteria of stable keratoconus, a little bit debatable. Some reports count on the Kmax or the K-mean, and so we don't the increase in Kmax or K-mean more than one diopter. This is a indication of progression. Increase in the refractive cylinder more than one diopter is an indication of progression, and increase in the refractive sphere, which is less important than the refractive cylinder and the Kmax. The other thing we have to address is the shape of the cornea. We have to improve the shape of the cornea. We have two techniques, either the intracorneal ring or the PRK. And the intracorneal ring reduce the corneal steepening and decrease irregular astigmatism, and it push the corneal, the keratoconus cone into the central of the cornea. We have this case of the patient. We have the left eye, the best corrected vision is 0.4. I decide to do, this is the preoperative pentacam. And so we decide to put one segment of Kira ring, and this is the difference between the pre-operative and the post-operative. We can see flattening on the cornea, and the central cornea become more regular. And this another case. This is the best corrected vision is improved from 0.4 to 0.7, and we can see here the astigmatism is reduced from 8 diopters about 3.7 diopter. Another case of she's a 20 years old female. She has also keratoconus both eyes, and we decide to this is the preoperative pentacam. This is the right eye and this is the left eye, and this is also right and left eye. So we decide to put two segments of Kira ring in both eyes. And this is the plan of the surgery, and this is after the surgery. The best corrected visual acuity improved from 0.4 on the right eye to 0.7, and from 0.3 to 0.6. This is another case of also, this is this patient has bilateral keratoconus. The right eye is we are going to do bulk, and this is the left eye, and we put both two segments. This is pre and this is post, and this is the difference. We can see improvement on the best corrected visual, improvement on the astigmatism and the sphere from -7 to -3. Okay, this is another case. We can use also asymmetrical Kira ring. The symmetric Kira ring has different thickness along the length of the segment itself. So this is a pre-operative and this is a post-operative. We can also see the flattening of the cone and decrease on the size of the cone. The other mechanism or technique to improve the shape of the cornea is to do the PRK. The PRK, we have two options: either to correct only the high order aberration or to improve the shape of the cornea, or we can correct also part of the refractive error of the patient. In this case, we correct only the high order aberration, and this is also before. This is also another plane. In this patient, we correct both part of the high order aberration and part of the refractive cylinder, and this is the plan of the patient, and this is what we get after the surgery. So we improve the cornea from irregular astigmatism, lower steepening, to more regular astigmatism, even if the cylinder is increased, but it's become more regular in shape. And also we address the coma aberration, which is the most common aberration on the keratoconus. And this is the visual acuity simulating. We can see also improvement of the visual acuity of the patient. The point spread function also is improved. The last things to address is how to correct the remaining or the residual refractive surgery. The only option is to do the ICL, the toric ICL. Alignment of the toric ICL is very important in every astigmatism. It's very important, especially for the keratoconus. We have two options: either with the mark, the manual mark, as we see here, or we can use the digital imaging system. This is the Callisto system. So after inserting the ICL, I put a mark, and also after putting the ICL, just 1 minute, please. And we confirm the toricity, the alignment with the Callisto, and we have also here the other system, which is a Varion. First, we are doing registration. And then we can adjust our axis. The last option is to do bulk, and this is very advanced keratoconus. Thank you so much.
Thank you, Dr. Sherif. You highlighted all the options for the irregular astigmatism. So this is a very good. But in your opinion, when you choose the axis in cases of irregular astigmatism, how you are going for the axis and the magnitude of the astigmatism in cases of irregular astigmatism, or in cases you are going to put a toric phakic IOL?
You mean before doing the corneal ring and
Yes,
yes. Before choosing is depending on many things. First, the key reading, the corneal thickness. This is very important, and how much I need to remove from the cornea to correct the high order aberration. So I have to correlate how much I need to remove with the corneal thickness with the stage of the keratoconus.
And the axis of the astigmatism.
I'm taking the refractive axis of the
refractive axis.
Yeah.
Okay. Thank you. So we are going back to Dr. Khalid Al-Arfash. He's here. So as scheduled, he's going to talk about why the femtolasic is my first choice in my refractive practice. We were going to see.
Yeah. Thank you so much, Dr. Ashraf, for nice introduction. And I'm sorry for being late. And the opening ceremony and the schedule was really busy. What is I gave you. I uploaded my presentation. Yeah. Yes. Yes, please. Thank you. This talking.